eyes की power कितनी.
Correct.
The second point is that the person says, I've done my surgery for cataract. Now, this only speaks volumes of the unawareness that our patients have because they haven't been counseled of what all havoc sugars can wreak. So, obviously, annual fundus is what I get checked in every diabetic patient. Uh, Sometimes I do it myself, but I think ophthalmologist would be a better person equipped to do that. And once the complications start to happen, I will not be naming them here, the aneurysms, the X-rays, hard and soft, whatever. No, I will not. But if that happens, then obviously ophthalmologist should be taken first up, and his help should be sought as and when required. There is something called bleeding in the eyes, in the layman's term, the vitreal hemorrhage, or sometimes even the main spot of the eye where vision is formed from. There also, the new blood vessels get formed, and they actually cause blockage of that area. Not blockage, but then the light cannot penetrate there. So that is the problem. Now, some people will say, well, new vessels are being formed. Where's the problem? No, the problem is that they are being formed where they should not be.
Okay.
So they call it neovascularization. That itself can be a problem. So to prevent all this, I think ophthalmologist's help should be sought sooner than later, so that bleeding can be avoided.
So again, it depends whether it's elective surgery or emergency surgery. We will concentrate on elective surgery. So again, before going for surgery, one blood glucose should be under control. So it's better to get the HbA1c done and see whether the HbA1c is under control or not. And also it's better to undergo pre-operative evaluations, so at least basic ECG, renal function test, that is a urea creatinine, those kind of tests to be done, and make sure that they doesn't have any other associated comorbidities. And also share the medication list with the surgeon doctor, discuss with the physician, because sometimes they may be on blood thinners like aspirin, cloplet, etc. So again, that increase the risk of bleeding. So if they are on those medications, again, depend on the surgery, we need to stop 5 to 7 days before the surgery. And also important thing is some anti-diabetic medication. The diabetic medication needs to be stopped before surgery so that the patient doesn't develop any complications. Like nowadays we are using this SGLT2 inhibitors kind of drugs very commonly. So those drugs need to be stopped at least 3 days before surgery. And if the patient is on injection called GLP-1 analog, those need to be started at least 1 to 2 days before surgery. And if the patient is on insulin, it depends on the types of insulin and number of breaks they are taking, and also their blood glucose control. We need to adjust the insulin, reduce the dose, and also depends how long the procedure will be there, and whether the patient will be kept on nil oral after surgery. So the insulin will be adjusted based on those things. So a lot of things are there. So it's better to discuss with the treating doctor, the endocrinologist, the diabetologist, and also the surgeon, and also decide what kind of plan they are going to implement pre-operatively, before surgery, during surgery, and post-surgery. In the next after surgery 1 or 2 days, they may be on nil per hour also. All those things has to be discussed before planning for surgery itself. And again, as I told, some patients will be on only drugs, not on insulin. So they should again ready for taking insulin during the perioperative period, because during hospital stay, if the blood glucose goes high, again they may be on multiple medication which can again increase the blood sugar level also. So during that time they may require temporarily insulin also. So they should be ready for those things also. So all those things has to be discussed with the treating doctor and the surgeon before going for surgery.
I think nutrition is the hardest nut to crack when we are managing diabetes. And because what we tell patients is very conventional, that is backed by science, and that actually seems boring. So people are looking for quick fixes, and that's why keto diets, for example, which are predominantly 75% fat diets and less, 5 to 10% carbohydrate, including fruits, are not allowed. So it's really a high fat diet, which through various mechanisms, which I will not explain just helps in weight loss. The important things about intermittent fasting are that ideally it's the fasting period should start in the evening and go on till next morning, not the other way around. What some youngsters do is miss breakfast and have their meals at lunch and dinner, that 8-hour period, because a classic intermittent fast is
So there is nothing like borderline diabetic. Either you're diabetic or non-diabetic or pre-diabetic. There are three different conditions, and all three of them need to be addressed in their own spaces. So there's a misconception or a myth about the diagnosis and delay of treatment. So that's one thing. And then there is the most common myth is about using insulin. People think they use insulin because they're at their tail end of diabetic saga of or diabetic life, I would say. So using insulin could be right in the beginning, right in the middle, right for a surgery or to get them under control for that moment. And sometimes it may be permanent, it may be early, it may be late. So
Very important. Emotional support, not just from the spouse, also from the kids, parents. Everything is very important in the long-term management. That only leads to a sustained management, and the sustenance of all the lifestyle requires definite family support. Without that, it will not be successful.